Good evening, everyone. It's nice to have everyone back again. This will be our sixth webinar for this year, ACNS Win webinar. And we are so glad to have everyone join us. Again, we'll be having an interesting session today. So I hope everyone will stay with us till the end. Prof. Kato, would you like to say some words before we start? Maybe something about Professor Yasagil, or maybe some moment for him?
Yes. We are so sorry about Professor Yasagil, the age of the 100 years old. Maybe almost the same year of my mother. Of course, my mother has passed away. So, but he is, I think, kind of the how do I say? Maybe the kind of the king of the neurosurgeon, because he taught us so many microsurgical skill, especially bypass. So we never forget. He taught us so many things. So I think maybe I think we give him that great confidence from all of us. Thank you very much.
Thank you, Prof. Kato. So today we have our chair, Professor Shunsuke Shibao from Tokyo Medical University, Tochigi, Japan. He will also be giving us one learning point and doing a presentation. So he will be the chair. We have two very exciting discussants who always join us. Thank you very much for joining us again this time. Prof. Hidehito Kimura. He's the Associate Professor from Department of Neurosurgery, Kobe University, School of Medicine, Kobe, Japan. Welcome, Prof. Kimura, and of course, Prof. Ahmad Fawad Pirzad. Thank you so much for joining us, and thank you so much for bringing in your women neurosurgeons from your country. So Prof is a professor in Kabul University of Medical Sciences. He's the Chief of Neurosurgery, Department of Aliabad University Hospital, and President of the Afghanistan Neurosurgical Society. So thank you for joining us today. So I think now I will hand over the session to our chair, Professor Shunsuke Shibao, to continue with the session. Thank you. You're muted.
Thank you. I'm honored to serve as today's session chair. So to begin the session, I would like to briefly present one learning point lecture on surgical approaches to trigeminal schwannomas. Can I start?
Yes, please.
Okay.
Yeah.
Okay. Share my. Did you see the?
Yes, Sensei. Please make it full screen.
Oh. Okay.
Okay.
I'd like to talk about a surgical approach to trigeminal schwannoma. The trigeminal schwannomas are rare intracranial tumors. The first-line treatment is surgical resection. As the trigeminal nerve is the largest cranial nerve, these tumors can arise along various segments of its long course. Consequently, surgical approaches must be tailored to the tumor's location and extension pattern. This slide shows the MEP classification. The M indicates middle fossa, P posterior fossa, E extracranial extension, subdivided into E1 for orbital, and E2 pterygopalatine fossa and infratemporal fossa involvement. MP type is most common, followed by P, M, and ME types. So this classification helps determine the appropriate surgical approach based on tumor extension. This slide shows the membranous structure of trigeminal nerve. As shown in A to B, the trigeminal nerve runs within the subarachnoid space from the subdural region to Meckel's cave. As shown in C, as the trigeminal nerve transitions into the peripheral branches B1 to B3, the arachnoid membrane becomes perinoidium and the meningeal dura becomes epinoidium. As shown in D, within the lateral wall of cavernous sinus, the trigeminal nerves run within the inner reticular layer enveloped by epinoidium. Based on this anatomical configuration, we classify M-type tumors into two subtypes, MC type involving cavernous sinus and MM type involving Meckel's cave. The anterior transpectrosal approach is our standard approach for MP and P types trigeminal schwannomas. It provides direct access to trigeminal root, Meckel's cave, and lateral cavernous sinus. After temporal craniotomy, we drilled the calcium triangle to expose the pituitary apex. This triangle is bordered by greater superficial pituitary nerve, acute eminence, and trigeminal impression. We then open the middle and posterior fossa dura and ligating superior pituitary sinus and tentorium to visualize the entire trigeminal nerve. We prefer using the ATPA over the retrosigmoid approach for P-type tumors, as it is more favorable for preserving facial and cochlear nerves. To reduce invasiveness, simplified ATPA is used for tumors centered in Meckel's cave. This avoids ligating SPS and tentorium, thereby lowering risk of venous infarction and trochlear nerve palsy. Alternatively, endoscopic ATPA allows for intradural subtemporal approach through small craniotomy, accessing the inner reticular layer or Meckel's cave. This technique minimizes retraction and preserve important venous structures. Epi and interdural approach is ideal for the MC and ME type trigeminal schwannomas. It consists of two phases. First, epidural phase. It involves extradural dissection to expose key foramina, such as superior orbital fissure, foramen rotundum, and foramen ovale. Next, in the interdural phase, the tumor resection is performed from within the inner reticular layer. Importantly, the inner reticular layer serves as a natural barrier. It protects adjacent cranial nerves and cavernous sinus. So the subcapsular removal is very important. The zygomatic infratemporal approach is indicated for tumors extending into the infratemporal fossa E2 type. It combines temporal craniotomy with zygomatic osteotomy. Epidural dissection is performed along middle cranial base, and the lateral portion of the middle fossa floor is drilled to expose the foramen ovale. It is important to anticipate venous bleeding from pterygoid plexus. The endoscopic endonasal approach typically utilizes transmaxillary pterygoid approach. It is indicated for M and M2 type trigeminal schwannomas. This approach is particularly suitable when the tumor bulges into the sphenosinus, a so-called front door sign. Access is achieved by exposing pterygopalatine fossa via maxillary sinus. The sphenopalatine arteries divided, and the contents of pterygopalatine fossa are mobilized laterally in the superior austere plane. if necessary, the median nerve descending palatine artery and greater and lesser palatine nerves are also transected to secure a wider working corridor in the inferolateral direction. The endoscopic transorbital approach is particularly suitable for V1 predominant regions, but it can be also applied to M, MP, and M2 type trigeminal schwannomas. Expose the anterior temporal dura through the lateral orbital wall. At this stage, the superior and inferior orbital fissures and sagittal crest serve as key anatomical landmarks. For M-type tumors, anteromedial triangle, Maran triangle between B1 and B2 is utilized, while for E2 tumors, anterolateral triangle between B2 and B3 is employed. In conclusion, trigeminal schwannomas vary widely in location. We select the surgical approach based on tumor extension using ATPA, epi and interdural approach, or endoscopic techniques. Understanding the nerve's anatomy helps minimize risk and preserve function. A tailored safe strategy is essential for each case. Thank you for your attention. Okay. Thank you.
Thank you very much. I think I'll call upon our discussants, Prof. Kimura and Prof. Asad. Would you all like to start off the question session?
Thank you, Professor Shibao. Thank you for your fantastic presentation. So you talked about several types of the approach for the trigeminal schwannoma, divided into mainly three types of approach: ATPA and endoscopic and nasal, and transzygomatic infratemporal approach. Yeah. Also, additionally, you mentioned about the transorbital approach for the good approach. So minimize the surgical invasiveness for using the transorbital approach. So it's a nice approach for the, yes. So my question is just a transorbital approach. So the very new cutting-edge technique using the transorbital route is a good approach to minimize the surgical invasiveness. So how do you think about the extend the surgical corridor to approach to access to the pyramidal apex to remove the trigeminal schwannoma? So I think there if you get a wider corridor, if we widen the surgical corridor by using the transorbital approach. So, but I think that maybe the advertent event maybe occur, the optic nerve injury, maybe the diplopia, maybe suffering some post-operative complication may occur. So how to avoid the operative complication. So, but yes, I just want to ask you about it. Thank you.
Thank you for your question. Trigeminal, the transorbital approach, do you mean the transapex resection by transorbital approach is useful for the trigeminal schwannoma? Okay.
Yeah.
Maybe it is possible and maybe useful because the transorbital approach route is parallel to the tumor axis. So it is reliable direction or approach of transorbital approach. But the posterior region is very large. If the posterior region is very large, maybe it's difficult to remove by transorbital approach. Other approach may be added or combined. For the complication of the transorbital approach, I think it is important to collaborate as a plastic ophthalmic plastic surgeon. So we get the advice from the other department. Yeah.
So, yeah,
Okay.
I totally agree with. Yes, we have to collaborate with another department, doctor ophthalmologist, and sometimes the plastic surgeon. Of course, the head and neck surgeon also include our collaborate each other to perform the transorbital approach. Some kind of yes.
The protection is very important for the orbital contents protection, I think.
So, what is the limitation of the transorbital approach for access to the trigeminal schwannoma? So, as you mentioned in your presentation, that the tumor embedded to the middle fossa, anterior cavernous, or something like that. But some tumor sometimes extend laterally. So, but in some situation, you need to approach traditional anterior transpectoral approach. You have to use a both approach for the one tumor. So, technical limitation for the transorbital approach. Yes, for the trigeminal schwannoma. Thank you.
Thank you very much.
So, what is that? Yes, limitation of the transorbital approach. Thank you.
Sorry. Limitation is I think the limitation is the posterior fossa region. But maybe transorbital approach is difficult.
I see.
Posterior dominant, posterior fossa dominant region.
I see. Thank you. Thank you for your excellent presentation. I learned a lot. Thank you.
Thank you very much.
Thank you.
Professor Fawad, would you like to ask any questions?
Right. Thank you. Thank you very much. Nice presentation, and it was very useful for us. But we, unfortunately, in Afghanistan, we haven't the possibility for surgery for trigeminal nerve and especially schwannoma, and it was for our experience is good, and we will when got the chance we will contact with you. Thank you.
Thank you for your comment.
Any questions from the floor? Pato, do you have any questions? Or
Aisha, any comments?
That was a very good presentation, Dr. Shibao. So we have similar philosophy, but we do not use a petrosectomy for removing the trigeminal schwannoma because the tumor has itself made space. So first you do an extradural dissection, and all the dissection is interdural if it is not a very large tumor. So you just cut the lateral wall of the cavernous sinus and you can follow the tumor even in the posterior fossa without removing the petrous apex. So this philosophy is Professor Goel's, and which we follow. Only if it is too huge, then if it is extending too much, then you can go intradural. But otherwise, most of the dissection is interdural. Even for the extracranial component, there will be a dural cover that is going down along the V2, along the V3, and the tumor is going along with that. So you can just follow it and remove the tumor. So recently I did a case with a little extension into, the extracranial compartment, middle fossa, and the posterior fossa. All was operated by this small temporal craniotomy and interdural approach, and I could get the whole tumor out. So basically the philosophy is similar, but what you have avoided cutting the tent and the sinus, I would say you can avoid the pitrosectomy also. You can straight go into the lateral wall of the cavernous sinus and follow the tumor. But very nice presentation. Thank you.
Thank you very much. I read Goel's paper of trigeminal schwannoma.
Yeah, and the orbit, I don't know, can you go into the middle fossa by the orbital approach or difficult? Because the tumor follows V1 from the middle fossa, it will go through the superior orbital fissure and follow the V1. So when you come from the orbit, can you follow the tumor into the middle fossa, or is it not possible endoscopically?
Transorbital approach is possible to the middle fossa.
Okay.
Yeah.
We have a question? Yes.
Hello, I have a question about transorbital approach. Can I?
Yes, please.
Can I ask?
Yeah.
Nice to meet you, Dr. Shibao. I'm Shibamoto from Shinyurigaoka General Hospital. I have a question for you. I'm very amateur for skull-based surgeon, skull-based tumor. So please tell me, so how do you approach to via the transorbital cavity? So do you approach from nasal cavity and do drill out of nasal septum, and do you approach to the post how should I say so post eye, or could you tell me the more details about orbital approach?
Okay. Thank you very much. Thank you for your question. I learned from the transorbital approach from the Korean famous neurosurgeon, Dr. Kong, Professor Kong, and firstly, the lateral orbital limb is partially removed, and the lateral orbital wall is drilled. So then open the anterior part of the temporal dura and frontal lobe dura, and we can see the meningoorbital band at the superior orbital fissure. Then we cut the meningoorbital band. We can enter the interdural space from the transorbital approach.
So, okay, so you means you don't embed into the orbital cavity.
Orbital cavity partially through go through the orbital cavity, and the posterior wall of orbita is drilled. The greater wing of sphenoid bone is drilled. It contains the orbital wall, posterior orbital wall.
Usually, orbital cavity contains much lipid tissues, so it's very difficult to approach to the orbital cavities.
Periorbital is preserved. So orbital content
is periorbital
membrane
is preserved.
So
I got it. Thank you.
Thank you.
Thank you.
Thank you, Professor Shibao. I think your approach from I think the supraorbital approach has caused a lot of interest with the group today. But thank you so much, because I think everyone's not so familiar with going through that approach, because it's quite, for us to be perceived, it's quite going far down, right? Okay, so anyway, if there's no more questions, I think I'll let you take over the session now and introduce our next two speakers. So you can take over. Thank you, Prof. Shibao. It was a fantastic presentation.
Thank you very much. Yeah. Can I introduce next speaker as a chair? Okay. Next, it is my great pleasure to introduce Professor Kazunori Shibamoto, the consultant in neurosurgery department of spine and peripheral nerve surgery, Yurigaoka General Hospital in Japan. This talk is titled Basic Knowledge of Spinal Disorders, Symptoms and How to Diagnose. Professor Shibamoto, please, the floor is yours.
Thank you for your introduction of me. Give me a second. I want to share the slide. なんとか。
いい気がします。
これで行きましょうか。
そうですね。
I'm sorry.
これで、
よく見えてます。はい。
I'm sorry for my bad preparations. So today's my topic is basic knowledge of spinal disorders. So first, I'd like to introduce my CVs. I graduated medical college at 2002, and I did residency at Osaka City University. During these 7 years, I had no interest in spinal surgery. At the time, I hate spinal surgery because I thought I was neurosurgeon. Why I did lumbar, I operate lumbar lesion. So I dislike spinal surgery. And then after residency, I moved to Ichinomiya Nishi Hospital located in Aichi prefectures. At the hospital, I met with Dr. Mizuno, who is my mentor. So I was attracted by spinal surgery because spinal surgery needs precise neurological examination and history taking. And then we have to read the images. So I was very, very appealed to this region. Then I started training of spinal surgery in 2011. And then in 2016, I moved to Saso Hospital located in Hyogo prefectures, and I started up spinal center. In this time, at this period, 70% of my operation was spinal surgery, and the other 30% was brains. And then last January, I moved to current hospitals. Now, all of my operation is spine. So this is my brief. Symptomatology and precise neurological exams are more important than operative skills, especially in spinal surgeries. I know operative skill is very important, but on top of that, symptomatology and the neurological exam are more important. So now I worked at moderate class of hospital. We have about 500 of beds, and we have 10 residents every year. So sometimes I work with them. So at the time, I feel scared about their stance of their stance for the medications. So they dislike taking history and hearing symptoms. As a result, their lack of symptomatologies. Instead, they prefer images on display. They are used to read CT and MR images, but they cannot read and watched X-ray images. So I don't know other countries same or not, but today I hear that majority of today's audience is young residents. So I'd like to make a presentation about basic knowledge about the spinal regions. So today's agenda is just following 4 points, but I have only 15 minutes. So when it passed 15 minutes, I stopped this presentation. So first, basic symptomatology of common spinal disorders. I'm sorry, this is not a slideshow, so all answer is already written. So first question, how do you think about this patient? Numbness is common complaints in neurosurgery clinics. How do you think when patient complains bilateral hand numbness? The answer is only cervical disorders because brain makes a symptom of contralateral side. So this patient complains bilateral hands. So this means cervical disorders. And you should you should hear more details about area of numbness. You know, medial nerve controls first finger to radial side of fourth finger, and ulnar nerve controls ulnar side of fourth finger and fifth finger. So patient numbness is located in the medial nerve area. The diagnosis is carpal tunnel syndrome. So you can diagnose only taking history and hearing symptoms. How do you think about these symptoms? So when patient complains bilateral hand and bilateral foot, symptom is numbness. So in this case, you should doubt cervical disorders and polyneuropathy like diabetes mellitus. To differentiate these disease, checking point is patellar tendon reflex. If this reflex is increased, you can diagnose as cervical disorders. And if this reflex is decreased, you can diagnose as polyneuropathies. I'm sorry. How do you think this case patient complains numbness of ipsilateral upper limbs? If the numbness is located in the dermatome, this implies cervical disorders, but patient complains fall of upper limb. You should doubt both cervical and cerebral disorders. Checking point is tension signs called sparring test and Jackson test. So sparring test is hyperextension of neck, and Jackson test is lateral bendings. So this test is positive. The patient will be cervical disorders, and you should judge. You should take the history about onset. If this symptom start suddenly, this implies cerebral disorders, but symptom onset gradually, this suggests cervical disorders. How is this case? Patient complains numbness of left side, upper and lower limbs. You should think about both cervical and cerebral disorders, but patient complains with numbness of face. This indicates the cerebral disorders like pure sensory strokes. How are these cases? Patient complains only lower limbs. If the numbness is located in dermatome, you can this suggests lumbar disorders, but the location is not limited. Patient complains fall of lower limbs. You should doubt both lumbar disorders and arterial sclerosis obliterans. To make differentiation, checking point is pulsation of dorsal artery of foot and localization of symptoms. And the fine movement disturbance is very important symptoms. In other words, it calls clumsy hands. Hearing about the following 4 points. Do you feel difficulties using chopsticks, opening a cap of plastic bottle to reach the button of clothes, and writing letters with pen? If patient complains one of these, this implies cervical myelopathies. And the intermittent claudication is very important to treat lumbar disorders. This is very famous symptoms. Leg pain induced by standing and walking. This is resolved by the rest with sitting. You can walk longer time if you use walker, cart, or bicycle. So in this case, walker, cart, or bicycle means the decrease of lumbar lordosis. So intermittent claudication indicates lumbar disorders and ASO. Okay, I have only 2 or 3 minutes left, so I want to finish agendas in seconds. Okay, so I proceed to how to read X-ray picture and diagnose with it. So X-ray picture is a basic test to read spinal disorders. Usually we take 2 pictures, AP view and lateral views. There are some points to check the X-ray pictures. In this case, left side is AP view. You should check the alignment and lateral spur. in this picture, there's no abnormality. And how is the lateral view? In this case, alignment is straight, and disc height is relatively preserved, but there's a small spur at L45 and LC6, and relatively big spur at LC6, C6 and C7s. And you should take the AP diameter. This diameter should be measured from posterior border of vertebral body to the inner layer of lamina, from here to here. If distance is less than 14 millimeter, bony spinal canal is narrow. And if the patient complains any symptoms of upper limbs, you should check the dynamic studies. How is this neutral position? Alignment is bad, and the patient, this picture shows mild kyphosis. And 2, 3, 4, 5, 6. At 5, 6, disc height is decreased, and there's a relatively big spurs. And if patient makes extension position, there's a instability at C6, 7. So you can't doubt here is winding regions. I ordered MR images 1 week after. This is the pictures. At this level, there's a T2 hyperintensity in the major spinal cord. How is lumbar regions? At the AP view, you should check the alignment and pedicle. Left side images shows normal findings, and right side shows scoliosis. If patient complains leg pain or leg numbness, you should doubt intervertebral foraminal stenosis. And the O-ring pedicle is very, very important findings. If the patient complains back pain, O-ring pedicle means disappears of pedicle. So now malignant cancer is common in our country and other countries. So when cancer metastasis to the spinal region, they embed into the pedicle first. So pedicle disappears. So O-ring pedicle means metastasis of malignant cancers. And you should take the dynamic studies. In this case, at L45, there's a rheostasis, and by taking flexion posture, there's an instability at L45. This is the offending region, almost 100%. So it passed over 50 minutes. So today I finish my presentation. I prepared other slide for more details, but today I have no time to present enough, so I finish.
Thank you, Professor Shibamoto, for your educational presentation. Is it okay you don't discuss the remaining item? You can.
Okay, okay. I made about 40 slides for today's presentation, but yesterday I noticed I have only 15 minutes. I cannot do every slide, so today I finish at this time. If I have another opportunity, I continue my presentation next time.
Oh, okay.
You want to share some of your operative videos or something like that, it would be fine. I think another 10 minutes. I think we are still quite early. We're not even at 7.
Could you say again? I cannot hear out.
I think Prof. Shibao and me, what we're trying to say is, if you want to finish off your presentation, it's okay.
Okay.
Yeah.
But it takes over 30 minutes. So today I finish.
It's okay. Professor Shibao's presentation was quite short, so we do have time. So I think you can present and to the end. Okay?
But okay, it's not. But today
fine.
we have next titles of good lectures. So today I do next time or other times.
Okay. Okay. Then now we will open the floor for question. Any question? Please chat or raise hands.
I think Professor Kumura and Professor Fawad, our discussants, you can go first.
Yes, I think I have to. I need to go first. Thank you. Or Professor Ahmad, or you have some comment?
Okay, go on, please. Go on, please. Thank you.
Okay, thank you. Thank you, Professor Shibamoto. It's fantastic presentation. But today you focus on the symptomatology and the diagnostic tool using the X-ray to see the spinal disorder. So I totally agree with you with your opinion that symptomatology is mostly important. The most important to see the spinal disorder, the accurate lesion detection is more important to, yes, before taking the radiological examination. We neurosurgeons recently tend to rely on the radiological examination before checking the patient's condition. Sometimes in Japan, we have abundant chance to see the MRI images. Yes, maybe in the stroke center we have here the 24 hours MRI scanning is always available for us neurosurgeon. But you mentioned in the symptomatology is very important. Yes, I totally agree with your comment. So I have one question. Okay.
Okay.
Thank you for given that you're finding
your opinion.
Thank you. Yeah, but I sometimes experience one patient come to my outpatient clinic, and patient is complaining the numbness and just a hand numbness. I thought the patient you may have some you may have some cervical disorder, some myelopathy or radiculopathy, or some you may suffering some kind of spinal cervical degenerative disease, I think, but. To rule out the brain is normal. To see I sometimes perform the MRI scanning, and sometimes I notice the patient suffered a small tiny infarction actually on the image. I have some experience some such kind of situations. So do you perform the MRI scanning to rule out to check the patient's brain is normal? Thank you.
Basically, I don't do because if there is small trivial infarction, there's no indication to treat, most of the numbness is derived from the cervical region.
Yeah.
So if the symptom is not severe, I don't order MR images, even both cervical and brains. If the symptom is getting severe, I ordered.
But nowadays, patients sometimes have the diabetes mellitus or hypertension or hyperlipidemia also suffered. In such a condition, maybe the patient
You
may
mean
have infarction. Yeah.
you mean patients have severe risk, so I may order. I'm sorry,
Yeah,
but
okay.
as you mentioned first, I'm very worried about the Japanese medical situations now. Young ER doctors orders MR images, even the patient symptom isめまい何でしたっけ
Vertigo.
Vertigo.
Business. Yeah.
Yes. So they never take the neurological examination. They cannot judge finger to nose examinations. They jumped into MR images.
Yeah.
This is big problem.
Big problem. Yeah.
I'm very surprised at these situations.
Yes, I agree to your comment. We have to see the patient first. Yes. I
Yes,
totally
yes, of
agree with
course,
your
of
point.
course.
Thank you. Okay. Now
Okay.
move on to the next comment. Yes, please. Thank you.
Thank you, Professor Kimura. How about Professor Pirzad?
Thank you very much. It was great and a nice presentation that learning outcome, and it's very useful for young neurosurgeons and also for neurologists as well. Thank you. It was so good, and we like to continue in the next webinars as well, the next slides as well. Thank you very much.
Thank you.
Congratulations for your good presentation.
Thank you. Thank you.
Thank you. Professor Shibamoto, I have one question. I'm not familiar with the spinal disorder, but most spinal disorder is maybe conservative for treatment.
Yes, of course.
So how do you decide between the conservative management and operative intervention?
So, okay, basically, so maximum conservative therapy failed, we should operations. So, first step is conservative therapies because the major causes of spinal disorder is generative change. So we should be carefully about thinking operative indications.
Okay, I understand. Thank you very much. Okay, I move to next speaker. Next speaker is Dr. Aiman Maidan from National Center for Neurosurgery in Kazakhstan. Her talk is titled Current Trends in Acute Ischemic Stroke Treatment in Kazakhstan. Dr. Maidan, please proceed.
Hello, everyone. Do you hear me well?
Good.
Okay, please talk.
And if you see my presentation very well, I'm so glad to be here today with you. And it's a great honor for me to share this this talk about current trends of acute ischemic stroke treatment in Kazakhstan. So as you can all imagine, stroke remains a big problem, not only for Kazakhstan, but worldwide. And you can see numbers of how many percentage of people suffer from stroke every year. But the most important part why I'm doing this talk today is that in Kazakhstan, we don't have neuroradiologists or interventional neurologists who, like in USA or Europe, do this. In Kazakhstan, neurosurgeons have to do these mechanical thrombectomies, and that's why I'm here today trying to represent all of the data. We try to evaluate our outcomes. To be honest, it's not like a very old, long time when we started all of this treatment. So we started relatively recently, and we wanted to understand how are we going for now. And we try to collect the data from 5 regions across the Kazakhstan from 2022 to 2024 and see how was the outcomes and key clinical and logistical parameters such as time from symptom onset, door to imaging time or door to needle time, or when we did endovascular thrombectomy, symptom onset to angiography time. And for you to better understand what I'm talking about, the Kazakhstan is relatively big country. We are 9th biggest country in the world, and the regions we represent is one in south, one in north, and one in east, one in west, and one is central. And you can see how many patients we had in every of these regions. And in total, we collected 672 ischemic stroke patients. And if you see by regions, the numbers here and patients per year, you can see they increased relatively good. So from the baseline, we can see that most patients were male, and some regions had relatively younger presentation, and median mix score was 12.9. And to clarify even better, we first, when stroke patient is admitted, we do thrombolysis treatment, and only if thrombolysis doesn't help, we proceed with mechanical thrombectomy. It is not in every center like that, but mostly it is like how we perform it. And as you can imagine, those patients who did not become better by thrombolysis treatment, they presented with worse NICS score at admission, and which you can also see later will influence the outcomes. And this is like representation of NICS at admission by regions. As I said before, we had 5 regions, and one of them had higher NICS score at admission, and one of them had lower, like you see, variant at our regions. So by years, we can also see that sometimes become less by time. So by 2024, median onset to door time was 98 minutes, which is for a huge country is relatively good. And interquartile range also changed, for example, for time from admission to intervention. And now we would go step by step by every of these timeline to every region. So for example, symptom to admission time was fastest in Kostanay and was 79 minutes. For example, for Spain, if we see presentations of stroke treatment, 79 minutes for them will be a long period, but Kazakhstan is bigger. And symptom to admission time also represents our emergency medical staff, like management, which can also influence on outcomes. Admission to CT time, it's also very different from regions, and the fastest is again in Kostanay, and longest are in Karaganda in Atara, as you can see. And we performed the post hoc analysis to verify, is it like true or influenced, and it was statistically significant. Symptom to treatment time, we analyzed thrombolytic treatment as well, and longest delays of initiation were in Abai, and fastest treatment initiation was in Kostanay region. And here you can see the graphical representation of what I already thought. And admission to treatment time was again fastest in North regions, and Abai region was the longest delay. It can represent some in-hospital protocol disparities or patient selection processes, or when we also need to understand that all these patients are first evaluated by neurologists, and only then we do like a meeting with neurosurgeons and trying to analyze and understand if the mechanical thrombectomy, which is also a very expensive treatment, will really help, and these all factors can influence on decision-making process. And the CT to treatment time was shortest in Karaganda and longest in Abai region, which also again can show some in-hospital protocol disparities. It is sad to notice, but in last month I was working in the hospital in the South region where CT even didn't work. So we had to transfer patients to another hospital to get CT and then transfer them back just to analyze what's going on inside the brain. So the procedure duration, the mechanical thrombectomy, Abai region had a median duration of 50 minutes, which is relatively good. And it was statistically significant. But despite the fact that the procedure duration was shortest in Abai, all other indicators, as you can see, like imaging speed, treatment delay, are worst in this region. Regarding the comorbidities, of course, all of these patients suffer from many comorbidities, but diabetes mellitus had most influential factor on poor outcomes. So classically, stroke distribution was mainly in MCA territory, and some cases were in internal carotid, like from cervical region to the terminus, and 20 cases we had of vertebral artery. Some patients required additional surgery, like additional angioplasty or one more thrombectomy after the initial attempt, and on the 9th had the compressive craniectomy. And bad days had very different percentages by regions, because number of patients was not very consistent. And as you can see here, bad days also increased by year. So outcomes, when we see MRS 5 and 6, we try to analyze which factors and which regions influence the most. And you can see that arterial has the highest proportion of favorable outcomes, and Turkestan of poor outcomes. And Abai region, again, as I said before, showed a notably higher rate of poor outcomes. Here are some kind of visual representations we try to make to represent the treatment type and on outcomes. But as I said before, thrombolytic patients had initially better mixed presentation. So it's not surprised that they had we had poor outcomes on thrombectomy group. And here you can see the representation of TC scores, which is also was kind of limitation, because not every hospital provided clear numbers of TC on the protocol of operation. So we needed to analyze by imaging and collect it retrospectively. And as you can see here, some regions had like a big varieties of TC outcomes. And this is the correlation between TC outcomes and mixed score at discharge. So if we do like the coefficient modeling, we can see that thrombolysis and due to treatment time had biggest influence on a better outcome. But it is the analysis of all patients, and hypertension, the absence of hypertension influenced better on a better outcome. And here is a comparison of NIH score at admission and on discharge. And again, you can see that mechanical thrombectomy group is performing worse, but it is not, it is mainly because they were worse on initial, on admission. And the overall median NIH score at discharge was 8, with interquartile range from 4 to 12. And you can see that some regions showed worse outcomes. And the forest plot showed that symptoms to delay in symptoms to treatment time or treatment duration time and age had the biggest outcome on MRS 5 and 6. And here are visual representation of functional outcomes by golden time treatment. So for thrombolysis is 4.5 hours, and for mechanical thrombectomy is 6 hours. And you can see the poor outcomes are relatively bigger in a delayed group. So the correlation between NICS at admission and MRS at discharge also showed a positive correlation, showing that it really influenced, which is not surprisingly, but we also tried to understand the regional disparities, which you can see here. All this presentation is not to say that some regions are best and other regions are worst. It's just to improve the treatment and improve the flow for our patients. We have published the paper. I have to notice that Dr. Ahmed, this acute ischemic stroke is his PhD thesis, and he is a leading doctor of this presentation. I'm just representing the data. And in this article, we try to provide the results of cross-sectional survey between hospitals, between different doctors across our country, and they all said that door to needle time and door to neuroimaging time is always not sufficient, like more than 1 hour or up to 2 hours in most cases. You can always read the paper, and we're always happy to discuss any points. That's it for now. If you have any questions.
Okay, thank you, Dr. Maidan, for your excellent presentation. Let's move to the Q&A session. Please, some question.
Can I give you a comment?
Yes,
Shibao?
please.
Thank you.
Okay.
Hello, Aiman. Nice to see you again here. Yeah, it looks so nice. It looks so nice. Yeah, I enjoyed always your Facebook channel. And yes, good, very nice channel. Very nice, yes, good for me to enjoy. Thank you. And yes, at first I visited the Kazakhstan at first time in 2015. At the time, I thought the same question. So, what's going on if about the ambulance system, the patient suffering the acute stroke? How can you transfer the patient to the emergency hospital? I didn't know this about the emergency car on the Kazakhstan and Almaty, and yes. Now you talked about your emergency acute stroke patients. So my first question is, how do you collect the patient data? Do you have some registry in your country, Kazakhstan? So big number of more than 617 patient data was collected in the same registry. Do you have some registry in your country?
We have like online communication system. It's called Damomet, and it started from 2022. That's the reason why we started collecting all this data. And it is relatively new and more or less comfortable, and it's across the country. But of course, to collect this data for Dr. Shayakmet's PhD thesis, we needed to ask, like doctors ask permission, and doctors, mostly like medical students or residents, collect the data of all of these patients. It's not automatically generated. And by making this presentation now, I also wanted to raise a question for all our Kazakhstan's colleagues, if it will be possible to make a prospective collection of all of this data, so it would be easier to analyze later on.
Okay, I see. So you collaborate with your medical student, of course, colleagues, so many your Kazakhstan colleagues. Yes, I understand.
Yes.
So my second question is how to transfer the patient on emergency to the emergency hospital? Just only an emergency car vehicle, or you do have some helicopter in your country, or something other emergency system?
Yes, it is like a very good point. We usually, patients arrive to emergency hospitals across the regions, and if like some special doctor is required, our country prefers to make by helicopter transportation of a doctor, not of a patient, because patient is in severe condition, of course. And but usually patients are distributed across the hospitals, and we come by helicopters only if there is no person who needs, like.
I see. Yeah, so my second question is what is the differences between you mentioned about the regional disparity between the outcome differences. What makes the
Yes.
difference between the regions? So I understand Kazakhstan is the sixth biggest country in the world, so huge. But yes, I think the difference may occur in the rural country or rural area, or the downtown area is different medical situation. Maybe assure. How about it? Thank you.
Yes, I think firstly, the biggest influential factor on outcomes is on like doctors' education. Like some regions for now lack like more standardized education than other regions. It is my personal opinion. Honestly, I don't know any doctors in this Abaya region which performed the worst. I don't know any of them, and maybe I'm wrong now, but personally, I believe that some in-hospital protocols could also be improved, that stroke patients should be initiated treatment as early as possible, because time is brain is time.
Yeah, I agree. Yes. So maybe the conclusion of your paper is improving the ischemic patient in Kazakhstan. Maybe you mentioned about your answer in your manuscript. Is that right?
Maybe we are still in the process of writing it.
Oh, yeah.
Thank you for all your questions.
Thank you.
Thank you, Professor Kimura. Any other question? How about Professor result. Please comment.
Thank you. Salam alaikum. Thank you very for a nice presentation and achievement. And I was also in Kazakhstan in ACNS Congress, and I have great memories from your system and your people. And now I saw your achievement. Congratulations. Thank you very much.
Thank you.
Thank you very much. Any other question? Yeah, I have one question. Okay.
That's great.
What are the current challenges in thrombectomy treatment in your country? Please teach me.
Yes, very nice point. So when I was like an intern or medical student 6 years ago, the best treatment was stent retriever, which is like relatively difficult to perform, as they say. And but when I finally become a neurosurgeon and we try to perform thrombectomies, it is more like aspiration now. So the process of aspiration is like when you just put the microcatheter on the vessel and start aspirating. It is okay, it helps by the data from USA or Europe, it helps, but I did not feel that I really do something manually. You all can understand that we are neurosurgeons, we like helping with our hands, and this aspiration is not making me believe that I really do something. I just put the microcatheter and switch on the aspirator. Usually it's penumbra, and that's it. And I don't know. I don't feel it's sufficient. I don't feel that it is like the gold standard, the gold treatment. So I believe engineers can perform better, or we can collaborate on more effective treatments, because thrombectomy by idea is a very good solution, very good treatment. It's better to do endovascular thrombectomy than open, because open takes like up to 2 hours. Maybe in Japan you are fast, it will take one hour, but in our reality it will take at minimum 2 hours. So I believe that endovascular is a good approach, but inside above of this aspiration, there should be something more efficient, something less complicated than stent retriever, but more efficient than aspiration. I believe so. I don't know.
Yeah. Thank you. Yeah.
Thank you all.
I will close the two speakers lecture. Thank you.
Thank you, Professor Shibao. And so we'll move to the next part of this webinar, where we have our WIN members from Armenia who are going to introduce themselves. So I'll call the first one, Dr. Ruzan Nazian.
Hello, everyone. Thank you for including me in WIN and also giving my colleagues the opportunity to introduce themselves. I'm Ruzan Nazinian, a neurosurgeon from Armenia. And I would like to point out that Armenia is a small but very beautiful and rich country which hardworking people, which is topographically located right in the middle of Asia and Europe. About my professional experience, I completed my clinical residency at Therapy #1 University Clinic of Neurosurgery and Comprehensive Stroke Center. The center specializes in open and endovascular treatment of cerebrovascular pathology, as well as neurotraumatology. From December 1st to February 12th, I had the privilege of completing my neurosurgery fellowship at Fujita Health University Bantane Hospital under the esteemed leadership of Professor Yoko Kato Sensei. This fellowship was a transformative journey, enhancing my surgical skills, expanding my academic horizons, and fostering lifelong connection in the global neurosurgical community. After returning from Japan, I was offered a better job, and now I work at Astric Medical Center, which is the only one in Armenia to receive JCI, Joint Commission International Certification, for the second time. This center also specializes in neuro-oncology and spine surgery. Currently, I am interested in advancing minimally invasive neurosurgery in Armenia and contributing to the development of a more unified and active neurosurgical association in the country. And at the end, I would like to take a moment to introduce my colleagues, Marta Kalashian and Anushka Zakarian. They are final year residents who are exceptionally hardworking, and I am confident that they will make significant contribution to the field of neurosurgery in Armenia as a female neurosurgeons. And thank you, Professor Yoko Kato Sensei. Thank you all, team WIM. Thank you.
Thank you, Rizan. So do Dr. Anushka and Dr. Marta, are you here? Are they here?
Yeah, but can you connect account Marta Kalashian as a speaker? She cannot share her presentation. She is in the list of participation.
Okay, she's here.
Marta Kalashian.
Is she here?
Yes, she's joining.
Yeah.
One.
Rosanna, you cut your hair?
Yeah, no, it's like this.
Okay. Right. So where she is?
Yes.
Oh, yes.
Hello, everyone. Let me share my screen. Can you see my screen?
Yes.
Yes.
Okay. Hello, everyone. My name is Marta. I'm from Yerevan, Armenia. I'm currently in the final year of my neurosurgery residency at Harati First University Hospital. Over the past year, alongside my academic training, I have also been actively working in the hospital, covering 24-hour shifts and managing emergency cases. At our center, we perform both open and endovascular neurosurgical procedures, allowing us to provide comprehensive care for a variety of conditions. So looking ahead, there are several challenges in our country neurosurgical field that need to be addressed. One of the most pressing issues is the lack of structured and modern educational program. However, I'm glad to share that a new neurosurgery residency curriculum is currently under development. So we hope that in time it will align more closely with international standards and significantly enhance training quality in our country. Another major challenge we face is the centralization of neurosurgical services in the capital. Most of our neurosurgical departments are located in Yerevan, while patients in provinces often lack timely access to emergency care. In some cases, it can take 4 to 6 hours to transport a patient from the most remote regions because it's up to 360 kilometers away from our capital. So solving this will take many years and strategic planning and infrastructure development, but I hope we can do meaningful progress in this case. And lastly, there are several subspecialties such as functional and endoscopic neurosurgery that are still underdeveloped in Armenia. And I believe that with collaboration, dedication, and international support, we can make a valuable contribution to the growth in these fields. Thank you all for your attention, and thank you for welcoming us into your community.
Thank you, Martha. I think Sharon, you can take over now.
Yeah, okay. So thank you so much, both Ruzan and Martha, for joining us today and introducing ourselves. It's nice that every month we get to go to the far parts of the earth and meet everyone. And if we can't go there personally, at least we know there are some women neurosurgeons out there. See more than what we used to have, right? Yeah, Abhi, when we first started off, I think there used to be such a handful, and Prof. Kato used to try to get us all together. Now it seems that there's a huge community, and in some ways, I think you're very lucky that you all have us around, and I hope you need anything, you can always reach out to any of us. All right, and then Abhi's, I think, is very. Abhi's actually offering, young women neurosurgeons if you want to go and train with her. And I think she's a great person to follow. Like, you've been with Prof. Kato. I think one of the things you all have to learn is, the presence of us working and, our work culture and how we work and how we cope with our daily life is something it's important that you follow and, and don't get disheartened. All right.
Yeah, thank you very much. And also we have another participant from Armenia, Anushka Zakayan. She is also final year clinical resident, and she's also hard worker, neurosurgeon. Please, Anushka, can you contact with us?
Okay, is she on? No.
Yes, it's the same account, Marta Kalashian.
Oh, okay, all right.
Yes. Hello, everyone.
Can see you. Oh, okay. Hi.
I'm
Okay.
Anushka Zakayan. Now I will share my screen.
Okay.
At first, I would like to say thank you to the members of the this community and Dr. Nazinyan for this opportunity to be part of this community. I'm Anushka Zakayan, and I'm from Armenia. I'm 4th-year neurosurgery resident, and my residency currently completing at the first hospital where I'm working as an on-call neurosurgeon and assist in surgical procedures. The neurosurgery department of the First University Hospital also serves as a stroke cooperative center. We are engaged in both general and endovascular neurosurgery. The department admits patients with ischemic and hemorrhagic strokes, cranial and spinal trauma, tumors, aneurysms, and herniated discs. Thrombectomy procedures are performed here for patients with ischemic strokes. A surgical microscope is available here, and when necessary, a relevant specialist is invited to perform neuromonitoring. From September to November last year, I was in Copenhagen, Rigshospitalet, as a fellow with the skull-based team, with Dr. Lars Porskat, Cor Fogelholm, and Jakob Springborg. During the first week, I participated in a skull-based course. Skull-based team of Rigshospitalet invited highly qualified specialists from other European countries to give lectures who first explained neurosurgical approaches to the skull base and demonstrated on cadavers, and then we did it on our cadavers step by steps with their supervision. After course, I was watching skull-based operations in OR, participating on some operations as second assistant, and in addition to the scheduled program, I also practiced vascular anastomosis on chicken wings and thigh arteries. I practiced on training microscope every day, and last week in November, participated in this dissection course that was performed by their medical Panam Institute. In the future, I'm committed to advancing my professional development in the field of neurosurgery. In particular, I am to
pursue specialized training in scalp-based and emergency neurosurgery. These subspecialties represent some of the most challenging and critical areas in the neurosurgical care, requiring a high level of expertise, precision, and rapid decisions making. I'm eager to expand my clinical and academic knowledge in these domains in order to provide optimal care for patients with complex and life-threatening neurosurgical conditions. By sharing my experience with colleagues and working together, I hope to help build a professional neurosurgical team. Thank you for attention.
Yeah, thank you very much. That was very great for you to share with us. So thank you, all of you from Armenia. I'm sure there are more of you. Maybe we'll get a chance to meet more of you in the next coming webinars. Prof. Kato, would you like to say something?
So thank you so much. So I think we can have a more Armenian female neurosurgeon. Maybe the Rosanna is top leading the female doctors in Armenia. Not, of course, not Armenia, but also there may be some kind of Central Asia. Is okay, Rosanna? Is it
Yeah,
Central Asia?
yeah.
Okay. So maybe we can have more chance to meet in some international congress in future, and or webinar.
Yeah, of course.
Thank you so much.
Of course, I will try. Yes. Thank you so
Okay.
much.
Yes, all the best. Okay, Sharon.
So thank you. Thank you so much for joining us today. Thank you, Prof. Shibao, for chairing this webinar, and thank you, Prof. Kimura and Prof. Prizat for being our discussants. Thank you, Abida, for always co-chairing these webinars with me. And I see Anyaku, you're here today with us. Nice to see you. You were a bit quiet today. Okay. Okay, so thank you, everyone. Good night, and see you all again in next month. All right, bye.
Thank you so much. Thank you. Okay.
Thank you.
Arigatou gozaimasu.
ありがとうございます。
おやすみなさい。
ありがとうございます。
ありがとうございました。
Thank you so much.
ありがとうございました。どうもお疲れ様です。